Hello and welcome back to Doc Talks. I'm Dr. Don Selby, a naturopathic physician practicing at Copper Valley Medical in Chandler, Arizona. Today's topic is PSA testing for the prostate gland. The prostate gland is a walnut-sized, walnut-shaped gland of about 20 cc's volume that is located just immediately under the urinary bladder but wrapped around the urethra. And all is good as long as it stays right where it is. Unfortunately, if it begins to enlarge, problems can develop. But here's a fact of life for all men. If you live long enough, your prostate gland will enlarge. Normally, it's benign prostatic hyperplasia. Sometimes the enlargement is due to an infection called prostatitis. And then the prostate gland may also enlarge because of a cancer, the prostate cancer. There are several potential complications from an enlarged prostate in a man. One is that the enlargement may compress the rectum, leading to a sensation that he needs to void or to have a bowel movement. Now, there may or may not be anything in the bowel that needs to be voided, so he can have an unproductive time on the stool and even strain long enough to get a hemorrhoid. In addition, the enlarged prostate may compress the urethra that it wraps around. This is going to impede urination. This can lead to a difficult time starting or stopping a stream of urine and may lead to dribble incontinence. On occasion, the enlargement of the prostate may also extend up into the urinary bladder and cause a blockage there. This commonly leads to nocturia, the requirement to get up several times a night to void the bladder, to dysuria, painful urination, and even to a sense of urgency, which can happen day or night. Sometimes the enlargement will block the internal urethral orifice. Now, this is a sphincter muscle, so the more the man is straining to pass urine, in fact, what he's really doing is contracting that muscle all the more. So men will complain that they have to get up at night, go void their bladder, and they can't do it. There's absolutely no way they can do it. They go back to bed, and as soon as they go back to bed, the muscle relaxes, and now they have to void their bladder. Very frustrating. Eventually, the man is going to be unable to void his bladder, which is very, very painful. This may lead to a bladder infection known as cystitis. It may lead to water in the kidney known as hydronephrosis, and it can even cause renal shutdown, which can be fatal. At the very least, when there is the inability to void the bladder completely, the man is going to have to visit the emergency department and have the catheterization, which most men don't really like, with some prescription of antibiotics to prevent prostatitis. But the big question on everybody's mind is going to be, what if this is prostate cancer? Prostate cancer is important. It is the second most common cancer in men, and this year, 2018, we predict 164,000 men will be diagnosed with prostate cancer. That means between 1 in 6 and 1 in 9 men in the United States will be diagnosed with prostate cancer sometime during their lifetime. It is second only to lung cancer as a cause of cancer deaths in men. Again, about 29,000 men will die of prostate cancer or with prostate cancer in 2018. This is not a young man's disease. This is a disease of the more mature male. 60% of cases are 65 years or older. It is rare before age 40, and the average age of diagnosis is going to be about retirement age. Genetics do play a role in this. Men who are of African descent are 1.6 times more likely to have prostate cancer. And if you have a first-degree relative, read that as your father, who has prostate cancer, you have a 2.5 times higher risk of developing prostate cancer. So this is not to be taken lightly. But our question becomes, if it is detected early, will it save your life? In general, we presume that when cancer is detected early, it's easier to treat, therefore it's more likely to be cured. The problem with this is that prostate cancer, we designate this as CAP, is a slow-growing cancer. A man may have a prostate cancer that never causes symptoms and never becomes a medical problem. That is, it will not metastasize to other parts of the body. In fact, we estimate that there are 29 million men in the United States right now living with prostate cancer, many with absolutely no signs or symptoms. When it is determined that it is appropriate to do an evaluation for prostate cancer, there are several tools available to the clinician. The most common by far is the prostate-specific antigen test. It is a simple blood test in which a specimen of blood is drawn and evaluated for a protein that is produced by the prostate gland. Digital rectal examination refers to using a gloved and very well lubricated finger, that's a digit, inserted into the rectum to palpate for irregular nodules or hardening of the prostate gland. Imaging in terms of a transrectal or transurethral ultrasound or MRI may also be accomplished. In the case of a transrectal evaluation, a small probe is going to be inserted into the rectum close to the prostate and an evaluation done that way. Transurethral means that the probe is going to go through the penis and see if we can get it close to the prostate that way. Doppler studies are also used by some clinicians with a great deal of success. Biopsy is the only way to definitively diagnose any cancer, that is, using a tissue specimen and analysis by a cytopathologist. Let's talk about the PSA test because it is used so regularly. There are advantages and disadvantages, and the bottom line is that before a man is tested, he needs to make a collaborative decision with his practitioner as to the use of the PSA test. Here's the reason that we spend so much time thinking about the prostate-specific antigen test. It was not designed to be a screening test the way it is used today. It was cleared by the FDA in 1984 to monitor men who had prostate cancer and had had the prostate removed, what's called a radical prostatectomy. In 1996, FDA approved the PSA test to be used as a screening test, but only in conjunction with a digital rectal examination. The PSA test is not approved by FDA to be a standalone test. It can only be used with a digital rectal exam. Therefore, it has limited diagnostic value. In fact, nobody knows exactly what to do with the numbers that come off of a PSA test. There are certain activities and conditions that will increase the value of a PSA test and certain things that will decrease the value on a PSA test. PSA is going to be increased if a man has an enlarged prostate with BPH, which again is most males as they get older. Likewise, if a man has a prostatitis, an infection of the prostate, that is going to increase the PSA value. PSA will increase with age. It increases with erection, ejaculation within the previous 48 hours, trauma to the region such as certain sports injuries. Guys, you know what we're talking about. This is when you catch a soccer ball between your legs and you weren't trying to. Riding a bicycle, riding a motorcycle, riding a horse. And curiously, having a digital rectal exam, remember that has to be done with the PSA test. If that's done less than 48 hours before that blood is drawn, it's going to increase the PSA by 0.4 nanograms per milliliter. Decreased values of PSA come with obesity and certain drugs that are used to treat BPH. So on the one hand, if you have BPH, you should expect the PSA to be higher, but if you are using finasteride, dutasteride, or even saw palmetto to treat BPH, that's going to decrease the value. Also, some chemotherapeutic drugs for cancer will decrease the value of the PSA test. So, if there is an abnormal test result, what do you do with that? The more conservative thing for a clinician to recommend is that there be additional testing, which may include a biopsy procedure. These are uncomfortable to say the very least. There is pain, anxiety, risk of infection, but please do not ever let a clinician give you a preliminary diagnosis of prostate cancer. Again, it must be a board-certified cytopathologist based on a biopsy. So we presume that early detection leads to a better outcome, but here are the facts. If the tumor is a half an ml or larger, it's likely to be clinically significant as cancer. If it is under 0.2 mLs, it's going to be fully capsulized, and even over a 5-year period is not likely to increase in size, and it certainly won't metastasize. If the tumor is in between that is between 0.2 and 0.5 mLs in size, in about 13% of the cases, it will progress to a clinically significant condition. What that means is that the only cancers that we really care about are those where the tumor is at least a half an ml or larger in size. There are several options for treating prostate cancer, and with that, many potential complications. Some of the more common treatments include surgery, which can be a transurethral resectioning of the prostate, that is, clearing the prostate away from the urethra, or a radical prostatectomy, the complete removal of the prostate and seminal vesicles. Chemotherapy is frequently used, as is radiation therapy and hormone therapy. In the case of hormone therapy, a man is going to be given estrogen, which is going to be able to counter the testosterone. Men, you need to be aware that that is a feminizing hormone. All of these things do have complications. So, complications, especially from the surgery, chemotherapy, radiation therapy, will include urinary incontinence, sometimes permanently, bowel dysfunction, erectile dysfunction, and again, sometimes permanently and completely, retrograde ejaculation, so that when a man climaxes, the semen doesn't come out through the tip of the penis, but rather goes retrograde backwards into the urinary bladder. This can be quite painful, as a matter of fact, and there's always the risk of infection. So all of these treatments do have potential consequences that have to be considered very carefully by the man. The complications that may arise from treating prostate cancer are so significant that the U.S. Preventive Services Task Force, a group that advises primary care doctors routinely, has done an evaluation and determined that for every 1,000 men aged 55 to 69 years who is screened with a PSA test every 1 to 4 years, we will avoid 1 death from prostate cancer. At least 120 men will have 1 or more unnecessary biopsy procedures. Remember, each one of those carries risk that goes to infection, urinary incontinence, and erectile dysfunction. 100 men will be diagnosed with prostate cancer. And again, many of those prostate cancers will be the type that will never grow, will never metastasize, and the man will never have any signs or symptoms of it. Of the 100 men who are diagnosed with prostate cancer, 80 will be treated with surgery, radiation, or some other method of treatment. And again, most of those cancers were never going to cause a problem for the man. The man is going to die with the cancer, not from it. 60 of those 100 will have a serious complication from the treatment, which again includes erectile dysfunction, urinary incontinence, bowel dysfunction, infection, and other issues. Because of that, the U.S. Preventive Services Task Force has recommended that men under age 55 not be screened, men over age 70 need not be screened, and men that are age 55 to 69 that decide to have prostate-specific antigen screening should make the decision very carefully. You should discuss this with your healthcare provider and make the best decision that is available. If you decide to test, I recommend that you understand the limitations of the test, which is the reason we've done this presentation. I also recommend that you practice what we call prostate hygiene. So wait 48 hours to have the blood draw for the test after you've had an erection, intercourse, or ejaculation. Wait 48 hours after riding a bicycle, a motorcycle, or a horse. Wait 48 hours after receiving that forceful impact to the groin. Wait 48 hours after the digital rectal exam in the doctor's office. And discuss the results with your practitioner, and when necessary, get a second opinion. There are risks and benefits to PSA testing as a screening device. I urge you to make the best decision for yourself. If you have questions about this, please don't hesitate to give us a call or drop us an email at info.coppervalleymedical.net, and I am available to speak to groups about this topic on request. Thank you for joining us for this edition of Doc Talks.